eculizumab. Sorry, sounds like we just started recording. First question is, is the evidence adequate to demonstrate that the net health benefit of eculizumab added to conventional therapy is superior to that provided by conventional therapy alone? And as usual, I'd like just to turn back to the evidence author. Jeff, if you can give a very brief summary again of our evidence and the evidence rating, and direct the CEPAC to any tables in the evidence summary that you think should be particularly relevant.
Thanks, Steve. So for benefits, look at table 3, which is on page 6 of the handout, and focus on the REGAIN trial, which is the upper of the 2 trials, so the trial of eculizumab. And for harms, you can look at table 4, which is on page 8. But as you see, there were really there was no signal of excess harms. The only issue is the black box warning that requires vaccination from meningococcus before starting therapy. So we gave this a B+ rating, despite the fact that they didn't meet their primary outcome in the randomized trial, because of consistent evidence of benefit that was maintained through 26 weeks in the randomized trial compared to placebo, and then through more than 130 weeks, I believe, in the long-term extension trial data that have been published to date. And to give you a flavor, the difference in the patient-focused outcome, the MG-ADL, was an improvement of 3.5 points versus 1.5 points for placebo. And for the QMG, the more objective measure, physician assessment, including things like spirometry and dynamometry, measuring muscle strength, it was at 8 weeks a 4-point improvement versus 1.4 points in the placebo group. And again, we don't have the data reported here, but these continued through 26 weeks in the randomized trial, as I said. So those were clinically meaningful improvements. You heard when we model this, that led to big improvements in utility, so quality of life for patients. So we felt like that was meaningful. Yeah, I can take any other questions, but.
Yep, okay. So that, and it was a B+ rating, as you said earlier in the day. Okay. Go ahead and use your yellow hands. I think that will bring you up to the front of my screen, since I can't see everybody on one screen. It'll shift you over, I think. I'm not sure if there will be any questions or comments about the evidence on eculizumab. Again, this is a question about whether it is better than conventional therapy alone. Any questions about the data? I know we talked through it well before. Okay, why don't we go ahead and take a vote on the first question? All right. We should have 11 voting members if everybody's plugged into the system.
Sorry, some of us are having trouble logging in.
So we've restarted the voting software and you should be able to log in now, but let me know if you can't.
You're perilously close to getting 11 out of 11. Megan, are you still working your way into it?
I just got in.
Okay. Okay, great. Let's show the results. Okay, 11 yes and 0 no. Thank you. Let's go to the next question. This is the same population, and to specify again, these are antibody positive patients, adult patients. And now the question is about Efgartigamod. I keep saying Tigamod. I hope that's not upsetting to anybody who feels particularly affiliated with Efgartigamod. It sounds like a nicer name to me, so I may roll with it. So let's vote now, or let's discuss, I'm sorry, let's discuss whether the evidence is adequate to demonstrate that the net health benefit of Efgartigamod or Tigamod added to conventional therapy is superior to that provided by conventional therapy alone. Jeff, again, the brief summary.
Yeah, so this reflects the clinical trials. The same tables apply, but now the ADAPT trial, Efgartigamod, you see it had actually larger impact at 4 weeks than eculizumab, smaller impact at 8 weeks. And that reflected what happened over the long term. There was sort of a waxing and waning of benefit reflecting the dosing. There were no harm signals, so that's table 4, page 8. And a little more uncertainty because of the lack of real world evidence and uncertainties about how this would be dosed in the real world, which, as we heard, many patients can go a long time between dosing, but some patients, and those patients are reflected in these decreases in the benefit at 8 weeks, may require more frequent dosing, which may lead to more immunosuppression than and thus the harms associated with that, things that we didn't see in the clinical trial. So that was the one uncertainty in particular that drove this to a C+ rating for a C++ rating for us rather than a B+.
Okay, thanks. I would remind the CEPAC that we have, again, at our disposal, all of us, the 2 patient experts and clinical experts as well, if you wish to ask them anything in particular about the evidence or anything else about this. So Efgartigamod is on the table. Same voting question. Anybody have any comments or questions that they'd like to pose? Brian?
Yeah, I just wanted to point out that at 8 weeks, it's still minus 2.9, which is, minus 3 was the clinically significant or clinically relevant change. So even at 8 weeks, there's still a clinically relevant improvement. It's just not 6 as it was at 4 weeks.
The difference from placebo is 1.7. So people argue differently about these sorts of things, but yes.
Thank you. Martha?
Yeah, I just would wonder from the clinical experts, we haven't really heard about their experience in treating patients with either of these medications. And I wonder if they could make a comment about the sort of the anecdotally, the level of response that they see in their patients.
Well, we might focus that. I know Efgartigamod is not FDA approved yet, so it would only be known through its clinical trial experience. And I believe that Dr. Narayanaswamy has done research with that drug, but I'm not 100% sure of that. But let's let both she and Gordon answer if they have any perspectives. Pushpa? Oops, sorry, you're still muted.
Sorry. I do use eculizumab in clinical practice. At this time, I tend to restrict it to patients who are refractory to other treatments, so at least 2 treatments usually. Although that I think may change in the future as the algorithm evolves, and that's sort of one of the things we said in the consensus guidance earlier. It's very effective. I mean, this is just anecdotes again, obviously. So there is one gentleman specifically that I remember who had a thymectomy, who was on multiple medications, whose myasthenia gravis I couldn't control. Steroids would help, but he would have severe side effects of steroids. I actually even tried Rituximab on the gentleman. That was before eculizumab was out in the market, but did not help him. And he was sort of having me fill out disability paperwork, which he wasn't happy about, but he couldn't go to work. And then I started eculizumab, and he actually came back to me and said, it's like a miracle drug. He went back to work. He was doing great. It's another issue that he has a cancer now. And so that's, but his myasthenia gravis just turned around to the point that he went back to full-time work. So, and then the other situation where I use eculizumab, not so much necessarily for the effect, but because of severe side effects with other medications. Mycophenolate can cause a lot of diarrhea, and I have one patient specifically who just could not. I could not use mycophenolate on him. He couldn't take azathioprine for, I don't remember what reason, or I didn't want to wait for the time it takes for effect, which is quite long. And he was on steroids with steroid-induced side effects. So I actually changed him to eculizumab because of the side effects rather than how his disease was doing, and he did very well. So I'll let Gordon jump in here. So those are just two anecdotal experiences. It's pretty safe. I mean, nothing very much happens. I had one patient who no one had meningitis. I had one patient who developed a serious fungal infection and died. He was also on other medications, so steroids and mycophenolate. So,
All right, thanks. Gordon?
Yeah, I'm still trying to figure out how to pronounce Efgar, Steve. So you've now really confused me. But fortunately,
Oh, see, he has a good joke and then the internet just won't let him go. Gordon, we may have to circle back to you.
you're frozen.
Yeah, he probably thinks we're frozen. I think we'll probably have to keep going and then let it come back. I mean, I would, Martha, just to be fair, I would like Jeff just to remind folks what % of patients had no benefit from Efgartigamod. We may have heard an anecdote of one of the higher end responses. I can't remember that, but I think that was on Eculizumab, wasn't it? The one
That was on Eculizumab. Yeah, I mean, I think you know, I would have to look at it. We didn't really look at it as no response. The complete response was, you know, on the order of 40% at 4 weeks.
Right.
So we don't know long term. But that means that 60% didn't get, not a complete response, but got down to an MG-ADL level of 0 or 1, as Pushpa pointed out before. So that means, you know, a significant proportion of patients on Efgartigamod still have symptoms that are meaningful to them.
There did seem to be an incremental response in the ADAPT, though. In the second one, about another 12% of patients became responded in the second cycle, but then it seemed to sort of just sort of plateau there. Just one other issue about eculizumab, it doesn't work on all patients. I have another gentleman who I've used it for a whole year. He has refractory myasthenia gravis and it did not work. And I use it for a year usually and then stop, because in the studies, there were some, in Regain, there were some late responders. You know, they said everybody starts getting better at 1 month, but there were 3 months and they were late responders as you look. So after a year, if it doesn't work, I stop it.
Thanks.
Thank you.
You seem to be moving again. We got you back. If you wanted to try to come back in with what you had to say, sorry.
I think someone from Argenx must have booted me off for not pronouncing the drug right. So yeah, I mean, I can provide a good example that I think highlights an extra point or two regarding eculizumab. And this is it's actually really several points. So as an African-American woman who actually had what we used to refer to as a myasthenic myopathy. And so I think this highlights what I certainly would agree with some of the public questions are disparities in care. And she had been managed for some time on steroids and IVIG and had fixed weakness because she hadn't been treated with anything for a long time. And obviously this is a costly regimen, side effects from the steroids, and wasn't really responding optimally. We put her on eculizumab, and she has done, I wouldn't say it's as dramatic as the patient that Pushpa first talked about, but a very dramatic response, and it's allowing us to get her off of the IVIG. And that's a patient that I didn't think it was going to work. I see very few of these patients who have myasthenic myopathy anymore. I don't know if Pushpa sees these. I used to see him in fellowship, and it's really pretty uncommon. And so I do think it can be extremely effective. And this story highlights a number of things, but importantly, the ability to get folks off of other treatments that are both expensive and have significant side effects.
Great, thank you.
I'll just
yeah, we need to try to move on quickly. Unless if it's about is it about Efgartigamod?
No, ECU. So just one quick comment about it in terms of tapering other medications, as Gordon mentioned. So although the trial did not allow it, and we do end up tapering some of those medications using clinical judgment, and we have been able to. So
Great. Yeah, we're going to come back. By the way, we are going to come back to dosing in particular because it may influence the thinking of insurers as they think about their insurance coverage language and how that goes into that. So we'll definitely revisit some of these issues. So thanks. Any other questions from the CEPAC before we vote on Efgartigamod? All right, let's go ahead and go back to the voting slide, please. Okay, so is the evidence adequate? Demonstrate it gives. All right, that was quick. Thanks. Let's see the results. All right, 10 yes and 1 no. I think we're going to keep going to keep our momentum. So the third question is about distinguishing, pardon me, the benefits between the two drugs. So we're back with that same patient population, antibody positive. Given the currently available evidence, is it adequate to distinguish the net health benefit between eculizumab and Efgartigamod? Jeff, again, I know that we gave an I to that, but do you want to give any more context to it?
Yeah, sure. So table 3 is limited to the antibody positive population, but they are still different in that for the regain trial, they had to be refractory. So they were a more difficult to treat population. So you can't directly compare here. And also, we did a network meta-analysis where the company did provide us academic and confidence data at 4 weeks, but we couldn't do the same thing at 8 weeks where, again, Efgartigamod looks like it's not as good. So usually at 4 weeks, eculizumab looks better. At 8 weeks, at 4 weeks, Efgartigamod looks better. At 8 weeks, eculizumab looks better. But the populations are different. There's a lot of uncertainty. And there's no head-to-head data. So we really didn't feel like we had enough information to differentiate the two.
Okay, CEPAC, do you guys have any questions, comments? I will note again that we will come back to the age-old question from our clinical experts when we hit the policy roundtable of, if you have a patient in front of you, what are your considerations in picking one or the other, and how should that influence the way that insurers think about their coverage policies? So we will revisit that. But any questions from the CEPAC about the evidence on this now? Okay, seeing none, let's go ahead and vote. So given the currently available evidence, is it adequate to distinguish the net health benefit of these two drugs? Okay, the result is, okay, 0 yes and 11 no. Thank you. Okay, so now we skip through several questions that we are not going to have to ask because we have determined that we cannot distinguish anyway. So please continue with these slides until we get to question 6, I believe.
For Steve,
Did I skip 4?
Yeah, we still need to do the IVIG and rituximab. Yeah.
Oh, yes, we do. Apologies. All right. So we're still with that same patient population. Conventional immunosuppressive therapies not effective or have not been tolerated and who are antibody positive. So given the currently available evidence, is the evidence adequate to distinguish IVIG from that of eculizumab and Efgartigamod? Jeff, what we got on that?
Again, as you heard from our experts, they offer when the standard therapy, including immunosuppressives, don't work, what do they do? IVIG and rituximab are options that you've heard about. But there are no clinical trial data showing that they're efficacious in these populations. There are, as I said, there's one unpublished trial. I'm forgetting. Are we on? I want to make sure I do the right one. Yeah, for rituximab, there's one unpublished trial.
No, this one's on. We're asking about IVIG first.
Oh, sorry, IVIG. Sorry about that. So again, for IVIG, there's also an unpublished trial. We know it didn't meet its primary endpoint, which was the reduction in corticosteroids, but the data aren't there. How it compares to either eculizumab or Efgartigamod, we really don't know. So insufficient evidence was our determination.
Okay. Clinical experts, anything you'd like to add to that question, the interpretation of that question? All right, any questions from the CPAC, Steve?
Just to clarify, we're talking about IVIG as a maintenance therapy and not as a rescue therapy in this context?
Yes, I'm sorry, I should have stated that. Yes, it is used for maintenance in some cases, and yes, that's what we're comparing it.
Okay, any other questions? All right, let's go ahead and vote on question 4. I was trying to go too fast. So same population, given the currently available evidence, is it adequate to distinguish the net health benefit provided by IVIG from that of eculizumab and efgartigamod? All right. The answer is, okay, 10 no and 1 yes. We will keep going given the preponderance of the voting there. So we can go now, I believe, to 5. I still wanted to go too fast. So 5, as Jeff pointed out earlier, is the question asking the same thing about rituximab. So given the currently available evidence, is it adequate to distinguish the net health benefit of rituximab, from that of eculizumab and efgartigamod? Jeff, you want to talk about, is it BEAT-MG? Isn't that the name of the study? Am I wrong? I forget which one was which, but
yes, it's BEAT-MG is the rituximab trial, and I meant to point people to page 7. That's where we have a brief summary of the rituximab and IVIG results, and page 8, the harms. We also list them, those that we did have available. Again, unpublished data. Primary didn't meet its primary outcome. Really hard to compare with the novel therapy, so insufficient evidence in our estimation.
If it didn't differ from placebo, why is it hard to compare to the 2 drugs that we might feel are better than placebo?
Well, I mean, for instance, IVIG, even though they didn't meet their primary endpoint, and neither did eculizumab, if you want to be a purist, they did have significant improvements in the QMG score, or at least clinically important improvements. So a 4.6-point improvement versus 2.7 points in the placebo group. So even though it didn't meet its primary outcome of reduction in steroids, there were other outcomes that suggested it's clinically beneficial. And clearly, expert clinicians feel like it's beneficial. About 30% of patients with generalized myasthenia gravis actually are treated with maintenance IVIG. And similarly, a high proportion with rituximab without good clinical trial evidence or even other comparative effectiveness studies. So.
Okay. All right. New England CPAC, do you folks have any questions of Jeff or clinical experts or patient experts?
This is Jason. I guess I think this is a kind of generalizably important question, right? When we have a situation where there are novel drugs in a space that do have randomized trials and relatively robust data versus placebo, and then you're entering a space where there's a lot of things in medicine that we do without great evidence, but it sounds like it's routinely done. I mean, I think one thing that I've been struck by listening to the presentations and reading the report in detail is that lack of evidence both for rituximab and IVIG. But it's, I guess, so my question is, like, what do the clinical experts think? I mean, just why is it used so much with such bad? I mean, I guess I'm a cardiologist. A lot of patients got morphine for MI. You know, I guess there's a lot of things in medicine like that. But I mean, like, in your gut, even acknowledging the lack of trial evidence, do you feel like it's effective?
Steve, can I take a swing at this?
Yes.
I'm gonna see if I can get Pushpa to disagree with me. So I actually think it's very clear that IVIG works just from a clinical perspective, and whether it works better or worse, we don't know. I actually don't think that's true for rituximab and acetylcholine receptor antibody positive myasthenia, at least for a broad group of patients. The BEAT-MG was a very different trial. Patients had much milder myasthenia gravis, and as has been pointed out, the primary outcome measure was the ability to taper steroids. And actually, the more interesting result of that study was that placebo worked wonderfully at tapering steroids, which I think says something about how we overmanage patients with relatively mild myasthenia gravis. There was a hint in the data that patients who had more severe disease might respond, but my sense is that the expert community uses a lot less rituximab for myasthenia gravis than may have come across in that summary. And I guess I would also point out something that I think Jason made, a point that Jason made, is that the lack of data, we don't assume efficacy in any any agent, and we don't have good data that rituximab works in this. So and I'll be honest, I don't use it hardly ever in acetylcholine receptor antibody positive myasthenia, because when I've tried it, it hasn't worked particularly well. So I'm going to see if maybe Pushpa disagrees. I've been trying for a while.
Well, you're going to be disappointed again. So I agree. IVIG does work. I tend to use it more as rescue therapy than as maintenance, but I do use it as maintenance in the rare patient who does not respond to other medications. And I agree, rituximab, in my experience, does not work for acetylcholine receptor antibody positive myasthenia in contrast to musk myasthenia. But I will say that when we developed the international consensus guidance, it was very interesting. It just sort of shows us variation in care. I also wonder whether it has something to do with different populations, ethnic, racial populations, and I do not know. But many investigators from Japan, for instance, and I think it was Norway, there was a lot of difficulty in sort of getting consensus around a recommendation for rituximab. And that's why we went back and looked at this, and we were stronger this time with acetylcholine receptor antibodies. So I think there's a lot of variation, but overall, I agree with Gordon that in the US experience, at least, in acetylcholine receptor antibody positive myasthenia, rituximab doesn't appear to be a great drug. Sorry, Gordon.
I'm going to keep trying.
All right, Felucio, why don't you share some because I know we have spoken with the team has spoken with other clinical experts, and maybe it's somewhat to Pushpa's point that maybe even outside the country, but have we spoken to others inside the country who are, I guess, rituximab fans in some way?
Yeah, I believe we spoke to some clinical experts at the beginning of this project. I think one outside the country and someone in other parts of the country that are in the US for sure, that do have experience using rituximab, and in fact said in their system, they are trying, and they think there's an overuse of maintenance IVIG. And so they are trying to get some patients off that because rituximab does work.
So there you get it in all its clarity and pristine categories.
Right. And if you look, I'm sorry, go ahead. And if you look at all of the non-randomized trials, a whole bunch of series, it's all over the place. Series that work, series that don't work, it's all over the place.
All right, so we are now going to load the heavy burden of making sense of that onto the shoulders of the New England CEPAC. And let's go back to the voting question. All right. Given the currently available evidence, is the evidence adequate to distinguish the net health benefit of rituximab from that of eculizumab and efgartigamod? Please go ahead and vote. Okay, and the results. Whoops, I think we skipped past it too quickly. Can we go back to see it? I believe it was 10 no and 1 yes, but please tell me we don't have to have them vote again. Can we
try going forward now? Just one.
I'm afraid well, shoot. What happens are we having difficulty?
It was definitely 10 no and 1 yes. That was the vote.
It was 10 no and 1 yes, right? Okay. Who's managing the cursor?
It's me, Steve. I can't go back and show it without redoing the question, but it was, yeah, what David said.
Okay, well, you got to stay sharp here. Things move pretty quick. So, but I'm glad we had consensus on what it showed. All right, now into question number 6. Oh, there it went. It came back. Okay, we can go to 6. All right, Now we are into a different patient population. So again, take a breath. Obviously, these are patients, adults with GMG, and we still have the same classes of illness. And we still are saying that these are patients for whom conventional immunosuppressants have not been effective or not been tolerated. Now we're talking about the antibody negative population. So Jeff is going to remind us how big that is in the overall pie and what the data suggest, because the question is it adequate to demonstrate the net health benefit of Efgartigamod added to conventional therapy over that of conventional therapy alone for this subpopulation? Jeff?
Yeah, so this is the subset of the ADAPT trial that's described on the top of page 7, the handout. So there were 19 antibody negative patients randomized to Efgartigamod and 19 to placebo. It was exploratory analyses, no p-values or anything. And the MG-ADL responses were very similar, 68% versus 63% in placebo. But the QMG response was better, 53% with at least a 3-point improvement versus 37% in placebo. So that's the sum total of the data. In the paper, it's described as exploratory. Really felt like there was insufficient evidence to say whether the net health benefits.
Okay. So the team's rating was insufficient on that subpopulation, right? Okay. All right. New England CEPAC members, do you have any questions about that subpopulation? And we're obviously not asking it about eculizumab because it's not been studied, or at least I'm not aware of it being studied in that subpopulation. Okay, let's go ahead and vote on that question, please. Given the currently available evidence, is it adequate to demonstrate the net health benefit of Efgartigamod added to conventional therapy for patients who are antibody negative? There we go. Okay, 11 no, 0 yes. All right, now we are moving into a different set of questions. All right, the New England CEPAC is kind of aware of where these questions come from and their context. I know that some folks watching on the web will not be. So just briefly, again, if you remember my very opening kind of remarks, this is an effort to capture important contextual issues and potential other benefits and disadvantages that may in some cases lie outside the kind of empirical evidence and reflect our social or ethical values or priorities that we have. In other cases, they may be supported by evidence when we get into the potential benefits. The first two questions are going to be asked in a sense about any treatment for myasthenia gravis. So it's more about the condition and its state of current treatment than it is about any of these treatments that we're talking about specifically in this review. So for instance, what we're asking, I'll read it quickly, is when making judgments of overall long-term value for money, what is the relative priority that should be given to any effective treatment for generalized myasthenia gravis on the basis of the following considerations? The first being the acuity of need for treatment of individual patients based on the short-term risk of death or progression to permanent disability. So this is, again, looking at the acuity of need given short-term risk of death or progression to permanent disability. We'll ask about the magnitude of the lifetime burden of the illness in the next question. So often when we think about these contextual considerations, we do want to make sure that we are fully appreciating the perspective, as always, but especially perhaps here, fully understanding the perspectives from the patient and the caregiver perspective. So Adrija or Marcia, I'm not sure if you guys have any specific comments about the acuity and the risk of short-term progression to permanent disability. Any comments you'd like to add? If you have them, you're both muted right now, so I just want to make sure I'm not missing something. Okay, Marcia?
Well, there's acuity in terms of long-term I mean, this sounds counterproductive, but long-term acuity. So someone who has a lot of symptoms for a long period of time. And then there's the issue of crisis in myasthenia, where someone who's very stable could very acutely become ill. And that's really the purpose of having a drug that works and doesn't have the instability of the disease. You want to stabilize the symptoms so that the patient stays well and doesn't have a crisis. So I say it's a very high priority.
Okay, thanks. Adrija, would you like to add it?
Sure, I would definitely agree with Marcia and add that, as quickly to have a medication that can work as quickly as possible, or at the very least, to work as quickly as possible in combination with some other lesser potent or what have you drug is very vital. And it's vital in not just the early onset or diagnosis of the disease, but also, as Marcia was mentioning, the probability of having not even just a crisis, but maybe just a very intense or very symptomatic episode, which we often have without actually going to full crisis mode, but they can be just as, or very comparable in terms of its impact on daily life, workability, and just surviving to a healthier ultimate stage, I guess I would say, if that makes sense.
Yeah, no, it does. And it is, obviously, it's a unique condition in many ways. The chronicity with the flares creates an interesting clinical backdrop. The way this question is phrased, and again, it's usually meant to capture things that are going to kill the patient within 6 months or something like that, or leave them permanently disabled from some kind of progression of the illness. And I know that the model did not assume any change on mortality, certainly over a 2-year time frame going forward. So just asking the clinical experts, do you have any separate view on how you would think of the priority of this kind of condition, given its specific acuity of need and kind of risk of short-term progression to permanent disability? And I know that's hard to tease out from the lifetime burden, but any comments you'd like to share?
I can take a stab at it, Gordon, first, if, and then you can go. So, yeah, it's a little bit difficult when we talk about acuity, because we've got to put in context that in myasthenia gravis, nothing happens over a few days. It's usually over a few weeks. So that's one thing to bear in mind. So, but in that short duration of time, as Marcia said, lots of things can happen. I mean, patients can have impending crisis or crisis. So I think to get that better is an extremely high priority. Now, neither of these drugs that we know of, I mean, there's some data that's coming out, but as of now, we don't know that either of these drugs do anything in crisis. They haven't been studied. So we are then talking about preventing crisis, not necessarily treating the acute situation, but preventing crisis, which I think is a really important outcome.
Thanks. Or if you want anything to add, otherwise we can kick it back.
Yeah, I mean, I would agree. I mean, I think the one thing I would say is there are individuals, I've not done this, but I know of individuals who've used eculizumab in crisis and have found it effective. I would say that Efgartigamod has a disease or a mechanism of action that probably would work. And while I think our existing crisis management approaches are generally effective, for individual patients, this is an enormous issue. So I would agree, based on your description, Steve, that this is a high acuity.
Okay.
All right, high need, sorry.
Got it, thanks. Aaron.
The question for the clinical experts, do you have a sense of what the lifetime incidence of myasthenic crisis is among patients with generalized disease, and then among individuals who experience the number of such events over their lifetime?
Oops, Pushpa, sorry, you're muted.
Sorry. I don't know that we have clear numbers. The number 10% pops to my mind, and I don't know why, but maybe, Gordon, I'm remembering something else. The number of crises have fallen over the years. I mean, there's a study that sort of looks at it, and that's mainly because of developments in intubation, where we sort of preemptively intubate them before they go into crisis, etc. But even the requirement for that, even preemptively, you could potentially call it crisis. So I think it's 10%. And I don't know the lifetime in one person because it's so heterogeneous. Yeah, and so, but the number has gone down over time.
Okay, unless Gordon wants to.
Yeah, I mean, I think that I want to say in Regain, they may actually have the data on the percentage of their patients that have been in crisis. I could be wrong. And Pushpa, you always make me feel good because I felt terrible that I couldn't pull that number off the top of my head, and I would have guessed in the 10 to 15% of patient range as well.
Marcia, that might be something that your patient organization could suss out some way in a patient survey someday. I know it's a select sample of all myasthenia gravis patients, but it would be interesting to know.
I'll pass that on.
Okay, why don't we go back to the voting question then? So this one is about any effective treatment. So we're not asking you to weigh one of these treatments versus the other. Just if we were to have an effective treatment, how would we rank the priority from very low, which is A, to very high, which is E, based on the acuity of need for treatment of individual patients based on the short-term risk of death and progression to permanent disability. And Felicia very quickly found that it is 18% of patients in the Regain trial had had a myasthenic crisis. Thank you, Felicia. Okay, let's see the results. All right, so we've got 2 at low and 2 at average, 7 at high, and that's it. Okay, great. Let's go to the next question. Okay, as I mentioned, this next question is the same general idea about any effective treatment for GMG. And the question now is not the acuity, but the magnitude of the lifetime impact on individual patients of the condition being treated. Marcia and Adrija, again, I hope you feel like you've had a chance to comment on the larger impact on patients. We're even going to talk about the impact on caregivers coming up pretty soon as well. But anything else you'd like to add just to help, again, round out the perspectives for the CEPAC voting members on the magnitude of the burden of this illness on people over the course of their life? Marcia, you're almost uniquely set up to tell us about that, aren't you, given that you were diagnosed?
Yes, I sort of am. You know, as a 10-year-old and suddenly being afflicted with extreme weakness and inability to chew and have double vision and finally have difficulty breathing, it was frightening. And I wasn't able to go to school for about 1.5 years at all because I was so debilitated. Finally I had thymectomy and that improved me. And I was able to return to school. Later, you know, certainly there is a huge burden in terms of, you know, whether or not I had doubt about being married and having, you know, someone else being burdened with my illness, which flared from time to time, and then later with children. So it really did have a huge burden on me. And I just want to say that I went to my 50th high school reunion several years ago now, but my next door neighbors who were in my class, they were twins, they looked at me and they said, "We haven't seen you in a long time, but we didn't expect to see you here because you were so sick as a child. And we thought you'd be on the deceased list." I had to laugh, but it wasn't funny really. And I'm thankful I've had really expert medical care and great drugs to help me along the way.
I'm glad you disappointed them. All right, great. I think that was very, very helpful. Very important. Any other questions or comments before we move to the vote? I see Martha raising her hand. Yes.
So I would just like to ask about this notion of low, high, average priority. Is this in reference to all the other diseases that everybody experiences? I mean, what's the comparator here as we answer these questions?
That's a great question. And the answer is it's up to you. In general, we can't provide you with, we could provide you with a list of things that we think have the highest magnitude of burden. We did that actually for a while in our reports. We were looking at what's called the absolute quality shortfall. And that is one empirical way to look at it over many, many years. But it didn't seem to kind of meet the more comprehensive view that we thought that you wanted to take in this. So we're not giving you any specific benchmarks, but the general idea is, as you said, it's to, in the framework of all the different conditions that we want to be able to treat, do we want to feel that this one is significantly off the middle of the course, if you will, in terms of its lifetime burden of effect on people? All right, Austin?
Yeah, I'm recalling there was a very low utility value for patients in this condition in the modeling that we saw at sort of baseline 0.4 something. Am I remembering right? And maybe that's informative to our thinking on this.
Yep. Again, for those who are fluent in the kind of utility world, yes, that's a fairly significant burden. And if that's over many years, then you can certainly assume that this is a relatively high. But again, not inconsistent, as Dan said, with major depression and some other conditions as well. So it's in that mix of conditions that can certainly affect people over many decades. Okay, let's go ahead and go back to the voting question.
Adrija, maybe you wanted to say something?
Oh, sorry, did I miss? Adrija, please, if you wanted to say something, go ahead.
I just wanted to kind of add a couple of little points. I have been similarly poised to Marcia in the terms that I was diagnosed at a very young age, and maybe one of the youngest cases in the state at the time. And I wanted to just kind of reiterate, I guess, in the process of your further research and future trials, what have you, to keep in mind the time frame at which you are introducing the drug to determine its impact on the symptoms or improvement of the patient is so important. And I'm just kind of thinking back about a question or a comment earlier on in today's sessions when someone was talking about maybe the 2-year time frame, that may be kind of like a target area to determine what type of symptoms are going to be down the road, or how the disease is going to later manifest itself. I think because we are such a diverse group, it's really it's imperative that the trial work that you all are doing and that your data that you're collecting is very sensitive and responsive to the fact that these symptoms can become severe, whether it's at the early onset, but also can have a period. They can show up acute initially and then be stabilized, and then show up acute again and then be stabilized, and then it could change. The terms of the degree of impact or positive impact of the drug can change as you get older, or as you've had the disease for a longer period of time, and it may not impact you after a certain amount of years. And so then you need to go back to the drawing board and find another combination of drugs. So this illness and how it impacts every individual is so different and so unique. Just having the ability to have a variety of drugs to pull from and a variety of drugs to create our own unique cocktails is so imperative. So, the idea of just echoing the importance of considering the different timeframes at which you're introducing it to the patient, and if it's in a combination of another drug, and as well as how often you want to require the dosage of your drug, because having to go back for 4 weeks consecutively of an infusion, for example, is so burdensome on someone, whether it's a child who lives in a rural area like I was, or as an adult having to take off work to do an infusion. And so my particular neurologist, he kind of took a different approach where we would only do one infusion, and it was a larger dosage than the amount that people are typically taking. I do Rituximab, for example, in addition to steroids. And as opposed to doing, I think it was like 375 milliliters once every week for 4 weeks straight, we just do 1,000. in one time because I'm having to do outpatient check-in at the hospital, and it may take anywhere from 3 to 7 hours or what have you to do the infusion. So those things are, they're really from a patient's perspective, really important to consider, if I could just reiterate some of those.
Great, thank you. And we'll come back to some of those issues on the policy roundtable too, I'm sure. All right, so let's go ahead then and take the vote on this question. Again, from very low priority A to E, very high priority, based on the magnitude of the lifetime impact on individual patients of this condition. All right, thank you. Okay, we have 1 average, 7 high, and 3 very high. Great. Okay, now we're going to push forward, and I'm sensitive. I want to make sure we have time to talk through the overall value votes that are coming towards the end. But first, we want to talk about some specific potential other benefits or even potential disadvantages in a way. And here we are going to ask, and we're going to have to ask the New England CEPAC to go through each of these relatively rapidly. We're going to ask the questions first for eculizumab and then for Efgartigamod. So the first of these potential other benefits is the patient's ability to achieve major life goals related to education, work, or family life. And we're asking you, the CEPAC, what are the relative effects of eculizumab versus conventional therapy on these outcomes? So now you do have to think about how much better you think eculizumab is when it's being added to care for patients, and this broader effect, if you will, on patients' ability to achieve their major life goals. I will offer that I think we've heard great testimony from the patient experts and the clinical experts as well on this, but if anybody on the CEPAC would like to hear more or has a specific question before they vote, please let me know. Why don't we go ahead and show everybody again so that I can see faces? Great. Does anybody have a question on that they'd like to ask before we take a vote on that one? Okay, let's go ahead and vote. All right, so based on eculizumab's relative effectiveness, do you think it will have an A, major negative effect on this patient's ability, or an E, up all the way up to E, major positive effect? Okay, let's see the results. Okay, 8 minor positive and 3 major positive. Great, thank you. The next one is about caregivers. And I did suggest that we would want to hear from the patients again on this. We haven't heard too much about the broader effect on families. We are starting to run a little short on time, but Adrija or Marcia, would you like to add anything to what you think the panel has heard already about the broader effects of effective treatment on how it affects families?
I want to add something, this is Marcia. So I grew up near Philadelphia, but in southern New Jersey, and finding the best expert was difficult. And I wound up getting treated in New York at Mount Sinai, which had a big center for myasthenia at the time. It's really disruptive to your entire family when you get admitted to the hospital, when you go for a treatment, which takes all day, or even just a checkup. And, you know, my brother and sister really had to, they missed a lot of their life too, because they were sort of shipped off to neighbors and relatives. And when my mom and dad were taking care of me, when I was hospitalized in New York, my mother stayed with me for weeks on end. And that can still happen. I mean, I know that hospitalizations are much shorter now, but what, you know, families do are really significant. And my husband, who died just 4 years ago from pancreatic cancer, was internal medicine physician. And there were days when he had to call at the last minute and cancel all his patients because I couldn't drive the kids to school, or, you know, I needed someone at home. So it can really disrupt your family a lot.
Adrija, we heard some testimony earlier, and I think the panel does know, but this is a condition that can strike women in kind of childbearing years. So the term caregiver, they're often the caregiver, and so it can affect their family in a lot of different ways. Anything else that you might want to add to that perspective before the panel votes?
Gosh, so as it impacted me as my caregiver as a child really quickly. My mother, ultimately, she was a single parent. She did lose her job. I had a couple of crises that kept reoccurring. And as the most positive patient that wasn't identified as such at the time, of course, I was refractory. So I had long periods of hospitalization, multiple months at times, what have you. She was not able to manage being present for that in different states, as well as just maintaining her job. But fast forwarding as an adult, a few years ago, I had a couple of crisis periods that kind of lasted over the course of about 1.5 years. And my husband at the time had started a new job, and there were times where I was dealing with such severe neck and back weaknesses that as the primary financial or the breadwinner for the most part in my household for good periods of time, my having to travel to my job 45 minutes away from where I live became impossible. And so he would drive me in and work remotely from the city where I worked at, which is in New Orleans. And so things like that. I mean, he had to have a job that was flexible to some degree, or I had to find a ride to work or something because I couldn't drive, couldn't hold my neck up, and those types of things. So caregivers can be impacted on just your very basic level of just, having to be emotionally present, emotionally supportive, or even just their period of acclimation as to what you're going through, particularly as an adult, can be particularly stressful. And as an aside, as a woman who was going, I'm kind of on the backside, I guess, of the childbearing age or what have you, but the drugs that I was using, specifically the Rituximab, was very, very instrumental in me postponing, pushing back, having kids. And ultimately, I pushed it back so far. It's a little too late now, unless I'm just buying some kids, but which I'm not opposed to. But so that's just a little bit of it. It changed our family dynamic in terms of with my marriage, for example. So.
All right, thank you for sharing that with everybody. Thank you. All right, let's go back to the vote then on the broader effects on caregivers' quality of life and or their ability to achieve their major life goals related to education, work, or family life. This is asking about the relative effects of treatment with eculizumab. If you can go ahead and vote. All right. Okay, 1 no difference, 8 minor positive, and 2 major positive. Thank you. Let's go to the next question. All right, so this is tricky because these questions are usually most germane when we are comparing it to something that has a very different complexity of regimen. And here we're talking about adding it on as opposed to replacing something. Given the amount of time we have, I'm actually going to suggest that we skip this question because I think it will actually not serve the purposes of the final report that well. So let's go to the next question. Okay, here though, it's worth wrestling with a question that, again, some treatments have a lot more than others as far as the ability to help society reach its goal of reducing health inequities. So we're asking, is there something about this treatment in this condition that we think will help reduce health inequities in society? Now, again, just to give context, that is a combination of the way that it's delivered. Will it be able to be used by people who couldn't otherwise, kind of get to or afford effective treatment? Will it help a condition that has a very strong preponderance, for instance, of members from a disadvantaged community in the US? So those are the kinds of questions on the table. Austin, if you have a question or a comment.
Do we consider the treatment price in this question?
I would only insofar, to be honest, only insofar as if something were to come forward that was much less expensive, then that would create an opportunity to help us reduce health inequities.
Yes.
So yes, I think it's fair to consider that.
The challenge is that it pushes me in the other direction. If I don't consider price, I go one way. If I do consider price, I'm a bit conflicted.
Yeah, I think it's fair to consider price. Okay. We want to think comprehensively about the ways that it could or couldn't help us.
I think Austin and I are thinking the same thing. So it's fair to consider price in terms of the externality effect on patients who don't have myasthenia?
No, I'm even thinking of those patients. So if the price is very high, their access may be lower, whether through, barriers that insurers put on, or just if they're paying out of pocket or their copay or their deductible. So that pushes me in the opposite direction than I would otherwise if I wasn't considering price.
Even on the patients who have myasthenia themselves.
Yeah, exactly.
Yeah, I see what you're saying. Yeah.
Okay, other comments from CPAC?
Yeah,
Marcia?
I'm sorry.
Okay.
I'm sorry. I have caught several comments that myasthenia disproportionately affects young Black women, but I haven't heard that quantified. Does anyone have the actual numbers behind that?
Jeff, or
I couldn't find good numbers for, age distribution in Black women, or even the proportion. But maybe others know some.
I guess the idea came from somewhere that it's higher prevalence in Black Americans. I don't know where that came from. Marcia, do you happen to know?
There was an old epidemiological study out of the University of Virginia. It was done in Southwest Virginia, and it showed the Black population to be more impacted than other populations. But it's very old. Needs more.
Well, another topic for future research.
Yes.
Clearly. Okay, let's go ahead and go back. I'm sorry, Aaron, I didn't see your hand. Please go ahead.
So I previously, during just the discussion, had the same question as Greg. I found a paper. I don't know if it's clearly out of my clinical area, but was looking at the incidence of and mortality rates of myasthenia gravis crisis in presenting to U.S. hospitals, and there was a statistically significant higher rate among Black women at 0.01 per 100,000, and then the number for one comparator to white women was 0.009 per 1,000 person years, so a difference of 0.001 again in the outcome of presentation to hospitals. But it was statistically significant, but at least in that measure appeared similar to me. I don't know if, again, this is in brief searching, but I don't know if this is would be considered informative by the clinical experts to this question.
Okay, let's go back to the voting question then. All right, so what are the relative effects of eculizumab versus conventional therapy on society's goal of reducing health inequities? A major negative effect all the way up through to major positive effect. Okay. All right, kind of an interesting split here. We've got 3 at major negative effect, 7 at no difference, and 1 at minor positive. I think actually based on some of the comments, I think we can understand that the people voting major negative are thinking predominantly about the impact of the price or the cost. 7, I think, maybe viewing a balance between the two, and we've got 1% at minor positive effect. So let's keep going because I am sensitive again to the time. Now, I'm going to suggest that since the panel voted that the evidence was not adequate to distinguish between the two in terms of their net health benefits, that it's very likely you're going to vote the same on these questions for Efgartigamod as you did for eculizumab. In other situations, that relative effectiveness would be different, and you might have very different votes on these outcomes. But in order to kind of take us through to the final set of votes, I'm going to suggest that I preset in your mind that that's what you would probably vote. If you feel that there's something about Efgartigamod that's different than eculizumab in its relative effectiveness on these other potential benefits, then please let us know. But I'm going to kind of go voting question by voting question and see if we can just go through them pretty quickly. So 13. Question 13 is patients' ability to achieve their major life goals. If you don't have a specific reason to think of Efgartigamod differently, let's go ahead and vote. Okay. All right, we have one no difference and 10 minor positive. The next is going to be the question about the caregivers. Again, why don't you go ahead and vote? Very likely as you did on this question for eculizumab. Okay. All right, 2 no difference and 9 minor positive. The next question, I believe we will skip as we did with eculizumab. Okay, back to this question on society's goal of reducing health inequities. Please go ahead and vote. Okay, I think we are almost there. There we go. Yep, okay, good. You guys remembered your votes. Nice job. Okay, that makes perfect sense. And now we're going to turn, and we are about 5, maybe 10 minutes behind schedule. So into the home stretch, we're going to ask several votes about long-term value for money at current pricing. So we are back to the patient population that is antibody positive and loosely termed refractory by not being adequately treated with conventional therapy. So given the available evidence that we've all discussed on the comparative effectiveness, the incremental cost effectiveness, considering these other benefits, disadvantages, and the contextual considerations that we've been discussing, you get 1 vote on the long-term value for money of treatment at current pricing with eculizumab added to conventional therapy versus conventional therapy alone. And Dan, I believe I can't remember the exact number, but the incremental cost effectiveness was over $2 million per quali and or.
At the placeholder price for Efgartigamod, $2 million per quali gained. For eculizumab, it was $5.2 million per quali gained. And there's some, I guess, considerable concern from various panelists and others about societal benefits not being included. Just a quick rule of thumb, if we look at the annual health benefit price benchmark for each of these drugs at $150,000 threshold, we have eculizumab at about $20,000 and Efgartigamod supporting a slightly higher price of about $28,000. The differences that we see between the drug price and these costs would have to be completely offset by societal benefits. So we're talking about $200,000 to $400,000, maybe more per year in societal benefits in order for these drugs to be considered cost effective at their current price at $150,000 per quality gained threshold. So just to give you some idea of how much the societal benefits would have to be to offset the price of the drug.
Okay. And I know it kind of goes without saying to those of us who talk this language a lot, but it's really important for the patient community to hear that this is not a vote about whether these drugs provide value to patients or to families. In a sense, that is the clinical benefits balanced with the risks. That's part of what you saw those unanimous votes are. Yes, 11-0, that this provides benefits to patients and by extension to families, some of the other votes we took. This is that, in a sense, more difficult voting around the balance of that within the economic structure of how we can scale prices to that added benefit. And that's what the cost effectiveness ratio is meant to reflect. Does the CEPAC have any questions or comments before we take the vote on eculizumab, and then we will take the vote on Efgartigamod after that? All right, let's go back to that voting question. All right, I don't think I'm going to try to reread the whole thing for you again, but you know the language. A is low long-term value for money at current pricing, B is intermediate, and C is high long-term value for money at current pricing. All right. We've got 10 low long-term value for money and 1 intermediate. All right, so let's go to the next question, which is the same question, but asking specifically about Efgartigamod. And Dan, I'm sorry, this is the one that has the cost per equal value life year gained at 2 million, the other one's at 5. So otherwise, I think the situation is as Dan described it. Any questions about this vote on Efgartigamod before you take it?
Can you just remind us that this particular decision analytic model was based on a placeholder price, because there's not a real price yet, but it sounds like there's pretty good confidence of what that price will be, right? Because there's been public statements from the company or something like that.
Correct.
So yeah, and I can comment on the company in a public statement gave a range of possible prices. We picked the midpoint of that range. They stated that it would likely be priced in between IVIG maintenance and Eculizumab's price. And we picked the midpoint of those two, annual midpoint.
Yeah, no, it's helpful to hear that, because obviously in this particular model, the sort of very high price is driving this very, this result that's, very severely in one direction. So it's helpful, but it sounds like you have pretty robust confidence of where they're going to set the price.
Well, we can always talk about it in the next hour, but yes. We don't always vote on value, but when we feel like it certainly, when we can, it's helpful, I think, to be as transparent as we can about it. And given the company's statements, we felt like it would not be unreasonable to go ahead and vote. All right, let's go back to the voting. I'm sorry, Steve, go ahead.
Great, thanks. Can you remind me as well about the assumption around how frequently the product would be used? I think if I remember correctly, it was continuously for the 2 years of the model. Were there any sensitivity analyses done of less frequent dosing?
Yes, there were. We did a scenario analysis around 4 weeks on, 4 weeks off dosing, so every 2-month cycles. The question is how the product is going to be priced. Will it be priced at an annual price that reflects that dosing? And that's kind of unclear exactly how it will be priced. If it requires less frequent dosing, will it still be in the $450,000 a year range? So we did do those scenario analyses with the data we did have for every other month or every 8-week cycles, and but using that same price, and obviously it produced slightly less benefit because the effect wears off over time within those 8-week cycles, but we kept the price the same. And then in the report, and I don't have them right in front of me, but we do have reported out what the annual threshold price would have to be for these different frequency. And it was actually very similar. One of the main benefits is because of the administration cost of the drug being $1,000 per cycle roughly. And again, that was also a placeholder price that we saw, $12,000 a year if it's being dosed every month, or $6,000 a year if it's being dosed every other month. So there are certain gains if you can sort of stretch out that dosing, stretch out the frequency to every 3, every 4 months. A lot of it at these lower prices that the thresholds are at, a lot of those gains are because of the decreased administration costs. At higher prices, those administration costs become less important because the drug price just overwhelms those administration prices or costs.
Thanks.
Okay. Great. All right, let's go back to the voting question. Again, okay, for Efgartigamod at its placeholder price, given the available evidence, et cetera, please go ahead and vote on low, intermediate, or high long-term value for money. All right, and we have our last result. Okay, 11 low long-term value and 11 is low long-term value for money. Okay, thank you very much, CEPAC. That takes us to our break. We are about 6 minutes late. What I'm going to suggest is that we take a break until 2:15. And we will be right back then to start with our policy roundtable. Patients, with clinical experts again, and with payers and the manufacturer joining us for a look forward. So we'll see you all at 2:15. We can change that slide just in case people are, we probably can't change it easily, but we'll reconvene at 2:15. Thanks, everybody.